Guys, today we are going to learn about status epilepticus. This is a very important LAQ and an SAQ. And this video is not to build your concept. This is more of a revision video that you watch before your exams, or you've never studied this topic and you want a quick overview of the topic. Then this video is for you. Most of the information in this video is from KDT, and it's good enough for your exams, for Viva and for theory papers. So what is status epilepticus? It is when a seizure lasts for more than 30 minutes or there has been 2 or more seizures without recovery of consciousness. Then we classify the condition as status epilepticus. When there's recurrent general tonic and clonic seizures without recovery of consciousness, we classify it as an emergency, and we have to treat this to prevent death and brain damage. Coming to the treatment of status epilepticus, our first priority is always to see that the airway is patent. We have to check for ABC, and we have to make sure that the patient's vitals are okay, his airway, breathing and circulation. Then we give them 20 to 50 ml of 50% dextrose through IV infusion. We do this because hypoglycemia can be one of the reasons for seizures, and we need to treat the causative factor of the seizures. So this is the first step of status epilepticus treatment. We check for patent airway and we give them 20 to 50 ml of 50% dextrose IV to treat hypoglycemia. Then we give them lorazepam. We give this in the concentration of 4 mg, 0.1 mg per kg in children. We give this at the rate of 2 mg per minute and repeat after 10 minutes. We'll see that lorazepam has a more sustained anticonvulsant effect, that is, it lasts for 6 to 12 hours compared to diazepam, which lasts for 10 minutes, as you'll see in the next point. We know that this happens because lorazepam has a lower lipid solubility and therefore has a slower distribution, and therefore it lasts more in the plasma concentration, and it is less likely to cause thrombophlebitis compared to diazepam, which is more likely to cause thrombophlebitis and infection of the veins. Therefore, we prefer lorazepam as our first drug of choice in treatment of status epilepticus. Then our next drug is diazepam. We give this at the concentration of 10 mg, 2 mg per minute IV infusion rate, and we give this for 10 minutes. But the anticonvulsant effect of diazepam fades after 20 minutes, and it is more damaging to the veins. Therefore, we prefer lorazepam over diazepam. Our fourth step of status epilepticus treatment is fosphenytoin. We give this at the rate of 100 to 150 milligrams per minute. It is given by IV infusion, and the maximum amount that we can give the patient is 1000 milligrams. This is given under ECG monitoring, and it is given irrespective of response after giving lorazepam to the patient. Fosphenytoin is a must in status epilepticus treatment. Then, coming to our fifth step in status epilepticus treatment, it is phenytoin sodium. It is only given when fosphenytoin is not available, and it is injected at the rate of 25 to 50 milligrams per minute. Therefore, it has more vascular complications. Our sixth step is phenobarbital sodium. We give this at 50 to 100 milligrams per minute, and it is given by IV route, 10 milligrams per kg. It is used as an alternate to fosphenytoin when fosphenytoin is ineffective, and it helps maintain seizure-free state for short term before oral therapy can be started for status epilepticus or epilepsy in general. Then, for refractory cases that fail to respond to lorazepam and fosphenytoin within 40 minutes of seizure onset, we treat them by giving them midazolam, propofol, or thiopentone. You can remember this by remembering the mnemonic PTM. And we can either give or not give prioritization and full intensive care to the patient depending on their status. Some general measures that are always taken during status epilepticus treatment is maintenance of the airway, oxygenation, giving them fluid, maintaining electrolyte balance, BP, normal cardiac rhythm, and euglycemia. And we also have to take care of unconscious patients. We have to make sure that they don't get hurt. So now, recapping all the points of status epilepticus, we first have to make sure that there is a patent airway, and we give them dextrose to treat hypoglycemia. Second, we give them lorazepam. Third, diazepam. Lorazepam is preferred more than diazepam because lorazepam has a sustained anticonvulsant effect compared to diazepam, and it causes less infections of the vein. Then we give fosphenytoin. It is given even if the patient is reactive or not reactive to lorazepam, it is a must in status epilepticus treatment. If phosphonatoin is not available, then we administer phenytoin sodium and phenobarbital sodium. And if the patient is not reactive to any of these drugs, then we give them the three drugs that I mentioned earlier, which is propofol, thiopentone, and midazolam. So this is it, guys. This is all you have to mention in a question of the status epilepticus, and in viva you can just enumerate the drugs, and if you don't remember the doses, it's fine, but with repeated revisions you'll remember the doses. Thank you.